Okay, so the first case is, I just wanted to talk about ECMO because we've been talking about this a little bit at work related to COVID. So ECMO stands for extracorporeal membrane oxygenation. And there's two types of ECMO. There's veno-veno ECMO, which is the type that we're using more during COVID because this is better for severe lung injury. It presumes that the heart is still working and can still pump out the blood. In veno-veno ECMO, most of the time you're gonna, especially if you need very high flow, you're going to have two cannulas, one which will be in your IVC, and I'll kind of blow this up and go into more detail about this in a minute, and coming back in through your internal jugular vein into your right atrium. Veno-arterial is used more when there's severe cardiac injury, the heart is not pumping as normally, and the cannulas are going to be, one is going to be taking out the deoxygenated blood from a vein and putting the reoxygenated blood back into an artery, either the subclavian artery or the common femoral artery. So this is more for cardiac injury, so we're not using this as much for COVID, but for lung injury, we're using veno-veno. So the return cannula is usually in the right atrium, and the drainage catheter is in the upper IVC. You want these to be far enough apart so that you're draining off the non-oxygenated blood, putting it through the ECMO machine, and then returning it to the patient through the IJ into the right atrium, and it gets pumped out through the lungs, through the heart. So when we're looking at plain films of these, the venous catheter should be in the upper IVC or maybe at the cavoatrial junction. And then the return cannula should be in the SVC right atrial junction area so that it's flowing straight into the right atrium. There's also a dual lumen cannula. This is if you need a lower flow of ECMO. And in this case, you'll have one catheter, but it'll have two separate lumens. So one should be similar concept down in the IVC, and one should be in the right atrium. Does that make sense? You guys have any questions? One thing that came up in our practice was that we were seeing some requests for DVT studies. So in the setting of COVID, there's two situations in which there may be more requests for DVT studies. One is that they're following the D-dimers of these patients daily because D-dimer is a marker for the severity of disease. And then the other, and so if the D-dimer is 5 times the normal or it has a sudden spike, these patients are very prothrombotic, and that might trigger a concern for a pulmonary embolism or a DVT. The other is in this post-ECMO decannulation. So not that many patients are getting ECMO. We only have, I think, 2 to 3 patients at our hospital right now that are on ECMO. But this is something for severe ARDS where you need to reoxygenate the blood and take off the carbon dioxide. And these catheters are very large bore catheters. When the catheters are in, the patient is actually anticoagulated. So there is a risk that they develop hematomas, hemorrhage, and bleeding. And then after they take the cannula out, there's a risk of a thrombosis because they have to hold pressure in this region. So sometimes they'll ask for DVT studies to look for thrombosis within the first couple of days after decannulating after ECMO.
Aarti, I'd like to chime in. This is Anu here. That I have faced a similar situation of increase in requests for DVT studies. And I actually called the intensivist taking care of this patient once because I just, on one day, I noticed that they had sent out 5 requests for DVT studies. And I thought that was just insane on all these COVID positive patients. So what she told me is there is a small study that came out of Wuhan where they documented increased, because of hypercoagulability, increased incidence of DVT. And so now these requests are multiplying to no end.
Yeah, I think it's still like really in development and a little bit controversial, but I think that we know they're prothrombotic, but it might be even like a microangiopathy. And a lot of the patients are developing subsegmental pulmonary emboli. So maybe it's not necessary to get DVT or PE studies on all of them. So I think they're still in a gray zone and we don't have enough data about like when to use it. And so some places are using it a lot, other places, they're not. So my sense is that maybe we're overutilizing DVT studies at the moment, but in general, COVID patients are prothrombotic and they're developing some of these complications.
Right. So not fighting it much.
Yeah, yeah, we're doing a lot of them. But
And
we
then
did actually start a revised DVT protocol. So instead of doing compression, color, and Doppler, we're only doing compression. And then also after ECMO decannulation, we are considering just revising it even further to just do the IJ and the subclavian rather than the entire upper extremity, because that's the area where the compression, where the cannula was. And so we are considering, because our techs are getting, more concerned about exposure, and especially if you're in the upper extremity, you're close to the face. And
We've actually abbreviated ours as well, that we're not doing any below-knee veins for that particular population now.
Yeah. So another thing for COVID is, rise in LFTs and creatinine are common. And so we're trying to kind of triage those ultrasound requests as well.
I actually read an abdominal CT on a patient, a COVID patient that they sent in for acute kidney injury. And, I didn't expect to see much, but actually on the arterial and portal, and the patient for some reason got a CTA. On both arterial portal venous, I saw vague hypoattenuating areas in the kidneys on both sides. Both kidneys were edematous, like slightly enlarged. And these didn't look like pyelonephritis, or they didn't look like frank infarcts, but it was just a very heterogeneous enhancement pattern of the kidneys. So I don't know if that's some sort of an ischemic injury at a microvascular level. I don't know what to make of it, but that was just the observation I had.
There was a paper that just came out in Radiology, I think, and they were talking about neurologic manifestations of COVID that we're seeing on MR or head CT, and like because they get encephalopathies, and there's like imaging findings. I'm wondering maybe if this is like an abdominal manifestation of COVID, systemic. COVID.
Yeah, I bet you.
I want to see the case.
I'll send it to you, Nelly.
Okay.